I'm Elias Mosialos. I'm Professor of Health Policy at the London School of Economics and Director of LSE Health, the school's research center specializing in health service research, health policy, and health economics. And I'm delighted to chair this critical conversation on what happens when libertarian economics meets public health. We'll hear directly from Professor Adolfo Rubinstein, Argentina's former health minister, who offers a rare insider's perspective on the dramatic reforms reshaping Argentina's health system, and not only the health system, reshaping Argentina in general, under President Javier Milei. Beyond his academic and research leadership, Professor Rubinstein has been a leading voice of health equity and universal health coverage in Latin America, not only in Argentina, but in other Latin American countries. This combination of research experience, implementation experience, and ministerial leadership makes him uniquely positioned to assess the current transformation of Argentina's health ecosystem, particularly as the country faces unprecedented policy shifts and transformations under the current administration. President Milei's administration continues to navigate turbulent waters. While his coalition performed extremely well in the October 2025 midterm elections, sustaining Milei's mandate for radical economic reforms, Argentina remains in serious economic crisis despite promises of US bailouts and is far from out of the woods. Against this backdrop, Milei's approach to healthcare has been particularly stark, from substantial cuts to budgets, health budgets, to Argentina's withdrawal from the World Health Organization, but not from the Pan American Health Organization yet. These changes represent a fundamental departure from traditional equity and universality principles and perspectives. Argentina's health system undoubtedly needed serious health reforms and changes, but not the type of indiscriminate horizontal cuts symbolized by Milei's chainsaw approach to public health spending. Professor Rubinstein will speak for about 35 minutes, examining whether market-oriented solutions can deliver for public health or whether they fall short. This will be followed by 10 minutes of questions and answers. Please feel free to post your questions in the Q&A function at any time during this lecture, and I will put them to Professor Rubinstein during our Q&A session. Once again, my sincere thanks to Professor Rubinstein for joining us for this important discussion and session. Adolfo, the floor is yours now.
Thank you, Elias, and thank you very much for your invitation, and thanks to LSE Health. For this invitation to make this webinar to a so prestigious audience and an academic school. And I'm a physician, an epidemiologist, and a policy researcher. But to be in front of the top economists in the world, I feel very humble. Having said this, I will share my screen to start my presentation. This is a real good opportunity to present what is happening in Argentina this time and to try to go deeper in this, what I would say, a health policy experiment, the libertarian experiment. And the changes that are taking place right now in my country. With Elias, we published a commentary in The Lancet a couple of months ago about Milei's health reform. And we not only describe the public health measures, but also try to interpret the consequences and implication of this health reform. So in the first part of my presentation, I will introduce to the Argentine healthcare system in terms of its structure, coverage, financing, disease burden, and some outcomes in order for you to know, the context of these healthcare changes and reform. And in the second part, I will present the main characteristics and the consequence and potential implication of this Milei's health reform. Let's start with this sort of icebreaker. I don't know if you know the Chainsaw Man. Chainsaw Man is a Japanese manga comic that seems to be very popular, or I was said that it is very popular in English-speaking countries, particularly among older adolescents and young adults, who also made up a significant portion of the voters for Milei. The story is about Denji, who is an impoverished teenager who, after being betrayed by the Yasuka, merged with his cunning companion, Pochita. And this fusion grants him the ability to transform his body parts into chainsaws. He's then recruited by the government for, by a government agency. On the right-hand side of the slide, you can see Milei. Milei with his motosierra, the chainsaw. Let me tell you, and I'm not joking, that he says he often talks with his dead dog, Conan. So, Pochita and Conan. In the photo, you can see Milei using a chainsaw with Elon Musk looking from behind. Any similarity in the picture is just pure coincidence. Now, about a brief, let me tell you a brief story about why Argentines elected Milei. In November 2023, Argentina elected Milei as president, who described himself as a libertarian economist and anarcho-capitalist. And this election made a dramatic political shift in my country. He campaigned on the message that there is no more money. All the campaign was about that, no more money. And he pledged explicitly about sweeping public budget cuts while framing the state as an obstacle and distributed justice as harmful. In his 2025 Davos speech at the beginning of this year, Milei condemned wokeism as destructive, echoing rhetoric from the administration of the US President Donald Trump. So this political change represented a radical departure, as Elias said, for a society disillusioned with 4 decades of democratic governance since 1983. Argentina, which ranked among the world's top 10 economies by GDP per capita a century ago, now lags considerably behind other economies. Actually, is 75th in the worldwide rank. Here you can see some figures about Argentina. Argentina is an upper middle income country with a high human development index, as you can see there, which is, is second in the region, and one of the first healthcare spenders in LA, amounting to an annual per capita expenditure to around $1,500 a year, which is 10% of the GDP. Very high for a middle-income economy, and sharing this rank with Uruguay and Chile in the Southern Cone. As you can see in this slide, Argentina shares with most Latin American countries a healthcare system with a structure that compromises effectiveness, equity, and quality. Segmentation implies the coexistence of subsystems with compartmentalized financing, public, social security, and private, that cover different segments of the population. Typically, the social security sector covers employees in the formal economy and their families. The private sector covers higher income families, and the public sector, except in a few countries in the region, not in the case in Argentina, is reserved for providing care to the poor segments and the indigent population. Fragmentation, on the other hand, implies the existence of many entities within the same subsystem. This proliferation of actors increases administrative and transactional costs, reducing the percentage of funding that goes directly to health services. The combination of segmentation and fragmentation leads to duplication of health coverage, with adverse effects on efficiency, equity, and quality. In addition, direct payment of families amount 40% of health expenditure in Argentina, but out-of-pocket payment is half of this, around 20%, which is lower than other countries in the region. And the other half of private payments are prepaid. As you will see in a minute, the Argentine system is plagued by these structural problems to a greater extent than any other Latin American country. Here you can see a figure that compares life expectancy versus GDP per capita. And you can see that there is a moderate correlation among these variables, where Argentina is positioned in the upper tertile compared to other countries in the region. And here you can see the segmentation of the Argentine health system. Although all Argentines are entitled to receive free care from public health facilities, 60% of the population also have social or private insurance coverage. In this regard, and in contrast to what we can describe as real universal health coverage, as in most OECD countries, UHC in Argentina is rather nominal than effective. And just for you to look at this fragmented conundrum, here you can see what segmentation and fragmentation really mean in Argentina, with 24 public healthcare systems at the provinces, one per each province, because healthcare is devolved to the provinces because of our federal mandate. We have also more than 300 social health funds and almost 300 private health insurance. So the fragmentation is absurd. And if you look at the distribution of quintiles of the population with only exclusive public coverage, you can see, and in the blue bars, there is a huge social gradient from the first quintile, the poorest, to the fifth quintile, the richest. Look, more than 60% of the first quintile have only public coverage, in contrast to just 5% of the wealthier fifth quintile. And these are all the provinces in Argentina. The gradient is very much correlated with the previous slide. So the gradient of public coverage only by province from the poor to the wealthy. So the poorest provinces, like Formosa, is, the public health coverage only exclusive is more than 60% versus 18% in the city of Buenos Aires. Now, let's go to the social security system and look at the fragmentation in more than 300 social funds, mostly managed by trade unions in Argentina. And this is a historical issue, very important. And look that more than 70% of the health funds have less than 30,000 beneficiaries, which is considered as the minimum number to have a more or less stable risk pool. So I would dare say that 70% of the obras sociales, which are the social health insurance funds, are not viable in terms of delivery and financing. And I wouldn't like you to understand, this figure, but this is the social security scheme. I know it is complex, but as you can see, the monies flow from employees and employers to the revenue agency, which channels 85% to the funds to social health insurances, leaving 15% to get a pool called a Solidarity Redistribution Fund to mitigate the differences in the revenues collected among each fund. And this fund exists in order to guarantee the mandatory package of benefits, which is the PMO, Programa Médico Obligatorio. Until the current reform, there was one important change. And look at here. Private insurance company, which previously could not be incorporated in this scheme, so they were out of the scheme, were excluded from this scheme, now can only receive beneficiaries in agreement with a social health fund. That was before. Now, private insurance companies can compete freely with social funds to attract individuals and families. So before, private insurances could only be part of this this scheme just if they were in agreement with a social fund. But now they can directly receive the contributions from employees and employers through the Internal Revenue Agency and compete freely with the social insurance fund. So there is an empowerment of the private sector, very clear now. This is the health expenditure as a percentage of the GDP in a 5-year period. You can see that there were no much variation. Now is 10.5%, which is very, very, very high for a middle-income country, except in 2021 in the pandemic period where it was higher. More than 60% is consolidated public expenditure, so public plus social security. And of the private health expenditure, at least 50% is out of pocket. But if you compare all the Latin American and Caribbean countries in the out-of-pocket spending as a percentage of health spending, Argentina is one of the lowest. Is one of the lowest in all the region. So there is, I would say that the out-of-pocket expenditure in Argentina is fairly well in terms of percentage of the income and the health expenditure. Here you can see the mortality by cause. NCD accounts for more than 70% of the disease burden. This is, I mean, I would say very similar to the most developed countries, except that premature mortality and morbidity is much higher. But you can see that the distribution, external causes and communicable diseases are now much higher than before. It was COVID and I would say that the aftermath of COVID and dengue, but NCDs are more than 70% of the disease burden. And if you see, for instance, in cancer care, examine the variations across provinces through some examples of breast, colorectal, and cervical cancer, you can see huge difference in outcomes more than between the poorest and the wealthiest province. You can see difference of 5-fold difference, 7-fold difference in cancer prevention, the same, and are highly correlated with the gaps in public health expenditure per capita. I mean, the gap is more than 10 times between the poor provinces versus the richest province. Let's go now to the Milei's health reform, second part of my presentation. Let's go to some key measures in the current health reform in Argentina. What are the important changes that are taking place at this time? First, and I will try to go deeper in the next slides. First is reduction of the National Ministry of Health budget and weakening of national programs. As I said before, there is a federal mandate where the state, I mean, the federal state devolved the healthcare to the provinces. And until now, even though that healthcare is a responsibility of the provinces, the Ministry of Health have a lot of strategic, I would say, strategic planning to try to mitigate the inequity gaps between the poorest and the richest provinces. The second is increased decentralization of healthcare services from the national government to the provinces, which is a consequence of the first. So reduce budget on the one hand and devolving all to the provinces, even the national programs. And that's a problem, and we'll see in the next slide. Social security reforms in healthcare driven, market-driven, and with a greater emphasis of market forces. And as you can see, the incorporation of the prepaid private insurances to the social security scheme. Strengthening of the private insurance sector, strong alignment with the Trump administration policies in the United States, included, as Elias said, the bailout, a recent lifeline that the USA gave to Argentina to avoid a financial crisis that was, taking place 3 weeks ago, just before the election. Withdrawal from the WHO. Probably potential changes to the pharmaceutical patent regulations to align with this agreement between Argentina and the USA. And of course, as you know, uncertain participation of COP30, which is taking place in Belém, in Brazil right now. Argentina sent a very low-level delegation. What is the logic behind Milei's chainsaw reforms? First and foremost, as I said, a deep reduction of public health funds from the federal level to the provinces, arguing that healthcare, as I said, is constitutionally a subnational responsibility, which is true, since provinces have not delegated healthcare to the national level. Therefore, it's not a federal mandate to send money and supplies and drugs and everything to the provinces. It's a responsibility of the provinces, and they have the quota of co-participation. So they should spend the money from what is the scheme, the co-participation scheme. Of course, this approach weakens even more the Ministry of Health's pro-equity role and reduce crucial financial transfer to the provinces. Then, the restructuring of the social security system, allowing private insurance to compete directly with social insurance plans, as I showed you before, strengthen market-driven health reform, following other schemes in Latin America, such as those in Chile and Colombia, for instance. Of course, these changes might increase more resegmentation and income-based stratification, reduce cross-subsidization mechanisms, and erode solidarity principles. And finally, the creation of a health technology assessment agency to guide coverage and financing decisions for high-cost technologies, which is clearly an important step to advance the regulation of innovative drugs to make health systems sustainable over time, a decision that is supported I would say, by most of the players in the health sector, and was an ambition in my tenure to create this agency. But not surprisingly, it has been stalled since its announcement in March 2025. Why? Because it was announced that we will create an HTA agency because it's facing heavy opposition from the multinational pharmaceutical companies due to their concerns about losing market access to innovative drugs. And again, in the same alignment that Argentina is having with the Trump's administration. And what are some of the consequences of the federal budget cuts? The Ministry of Health budget, representing a third of total public sector spending, the federal level, decreased by 13% in US dollar terms between 2024 to 2025. And these cuts severely impacted key programs and institutions. For instance, HIV programs were reduced by 38%, vaccine programs by 7%, essential medicine coverage by 67%. These were programs where the resources were delivered directly to the provinces. The government also dismantled the National Cancer Institute and cut cancer prevention programs by 47%. And additional setbacks occur in sexual and reproductive health. For instance, the government halted the national procurement of essential reproductive health supplies. So, it decreased by large, including misoprostol and mifepristone, limiting access to this medicine where in a country where abortion was legalized in 2020. Budget cuts also impair community mental health programs, while public funding for health research declined substantially. These are the consequences of the budget cuts, the federal budget cuts in health and health research too. And here you can see two examples of how the government mismanaged a couple of public health issues that later turned out to be public health crises. In the 2023-2024 season, Argentina had the worst dengue outbreak in history. And dengue is a re-emergent disease, probably related with the climate change in Argentina. And in the last season, we had more than 500,000 cases and more than 400 deaths. However, at that time, the government delayed public awareness campaigns and resisted incorporating the dengue virus vaccine into the national immunization schedule. And this reluctance reflected, in a way, a broader ideological stance against preventive public health spending and centralized coordination. Another example, a very recent example, in August 2025, a scandal erupted after bacterial contaminated fentanyl distributed to hospitals. It is used in anesthesia in critical care units, was linked to nearly 100 deaths. And a lot of questions raised about the lack of oversight of the National Administration of Drugs, Food, and Medical Devices, and MAT, the Ministry of Health Drug Regulatory Agency. Again, this fact illustrates the consequence of the state's retreat from essential functions and also the limits of austerity. Argentina also announced its withdrawal from WHO, arguing for health sovereignty and criticizing WHO pandemic response, again, echoing the Trump administration position. Although the government claims that they will continue being a membership of the Pan American Health Organization, which is the regional organization, this decision to the withdrawal from WHO would exclude Argentina from disease surveillance systems at a global level, pandemic preparedness and response mechanisms, pool procuring arrangements, although in PAHO there are some, pool procure arrangements. We don't know really what would happen when Argentina, because this should happen in February of next year, 2026, the withdrawal. So what will happen with PAHO? Nobody knows. And we will also be excluded from the broader global health governance discussions and conversations on global health key topics like epidemics and pandemics, climate change, AI, etc. And this decision was taken only because it's difficult to identify benefits of this decision, except to be aligned with the Trump's administration, the same libertarian populism. In this case, MAGA, make America great again, would be make Argentina great again, and the government is saying this. But despite the government's push for these austerity measures, there are a lot of opposition for various sectors and actors that led to civil society movements and judicial rulings supporting the elderly, the retired individuals, and the disabled. The Congress, for instance, reinstated, recently, the funding for the National Children's Hospital, against the decision of the government to reduce the budget, funds for healthcare for people with disabilities, and provinces are also defending local public programs such as essential drug procurement and distribution to vulnerable populations. In any case, even under this ideological austerity, established institutions, norms, and networks with a strong people's ownership are still resistant the full dismantling of social protection. And for instance, see what happened in the US with Trump and the Obamacare. He could not dismantle the Obamacare, although he was, the desires of the Trump's government in the first term, and now too. And some of these reversals are also happening in Argentina nowadays. What's next? What will be the consequences of this ideological austerity? Although a comprehensive assessment of Milei's health policy remains premature, we'll see, they signal a profound ideological shift. The question is whether, despite austerity being reasonable in a country facing a long-standing economic recession and financial crisis, this austerity appears to be more ideological than financial. And Milei framed state retrenchment as moral and liberating, defending liberty from state intervention and enabling public acceptance of cuts. But with diminishing federal health responsibility and retreats from redistribution, Argentina departs from its long traditions in healthcare. And nobody doubts that Argentina requires, reforms to address persistent inequities, inefficiencies, disparities. But the current approach raises fundamental questions about the country's implementation strategy and concerns about worsening in the next future health outcomes and inequalities, particularly for vulnerable population. In other words, indiscriminate budget reduction combined with market-oriented restructuring might exacerbate rather than resolve underlying problems. Effective reform requires targeted interventions that strengthen rather than weaken mechanisms from cross-subsidization and risk pooling, promoting redistribution of funds from richer to poorer, healthier to sicker, and younger to older. But despite of this, as Elias said in the introduction, Milei won the recent midterm election by a wide margin, more than almost 10 points. I mean, from the second. So people are still supporting these changes and reform. Why? On the one hand, people are still frustrated with the economic decline and limited opportunity for individual social progress in the last decades, and still expect improvements in their situation. On the other hand, a large percentage of voters had fears of returning to the economic situation and chaos that they experienced in the previous government. So the coming years will be crucial for monitoring policy reversals, legal challenges, and measurable changes in health access and outcomes, as well as the political sustainability of this reform. And to conclude, what are the burning questions we need to answer? Not only in the Argentinian context, but also in the global health context. What Argentina needs, given its resource-constrained context and the economic recession? A chainsaw or a scalpel? How to safeguard universalism and solidarity under this populist and ideological austerity? Is it a global trend that is occurring worldwide? Maybe we need to reform the global health architecture in light of the current scenario. Should we? So these are just some of the asks that we have to debate worldwide, not only in Argentina. In developed and in developing countries, here and there, the sooner, the better. Thank you very much.
Thank you very much, Adolfo, for this candid and compelling analysis, and for outlining all the challenges that the Argentinian health system is faced with. Quite dramatic shifts, I would say. But it's time for Q&As now. And let me start with an observation before I read some of the questions that some of my colleagues and participants in this session have posed. You mentioned about the possibility now of people opting out from the social insurance organizations without getting permission to join private medical insurance entities. And this is definitely what is happening in Chile. So people can opt out from FONASA to join the private health insurance sector, and about 13% of Chileans are opting out at any time. And it is also revolving doors. So younger people tend to opt out from the public system. The young and the
richer.
Yeah, and they join the private sector. As they get older, though, and multi-morbid, and then because premiums are risk adjusted, they return to the public system to have whatever coverage they can get from the public system. Now, as I can see this in Argentina, that's my prediction. So this will happen, a similar phenomenon to Chile, that the younger and the healthier and the wealthier will opt out. And as this will push the small insurance funds, these hundreds of insurance funds that have less than 300,000 insurees, to amalgamate. But then what will happen is a large risk pool with the bad risks and the poorer people. So, and therefore they will not have money to sustain a high quality health system if they end up with the poorer and the high risks. At the same time, my prediction is there will be labor market implications in terms of the specialist doctors in your country. What happened in Chile is, although 13% of the population opts out from the public system to join the private system, more than 50% of the specialist doctors work for private insurance companies. So 50% of the doctors serve 13% of the privately insured, and the other 50%, 87%. So there is a huge imbalance, and those serving the 87%, they're serving higher risks. and the bad risks compared to the private system. So this could be not an immediate implication of this reform, but in the medium to the longer term, you're going to observe the labor market implications as well. Would you agree with this?
Yeah, of course, I agree. I would say, Elias, that this is happening now because the green scheming, I mean, happened from the first deregulation, that the health reform in the 90s, where the social health insurance could make some kind of agreements with the private health insurances, and there was an important process of green scheming at that time. Now, my concern is that this, with the incorporation, direct incorporation of the private health insurances, the prepaid health plans, this will go, this will worsen. And I completely agree. And these reforms, the market-driven reforms, like what is happening in Argentina, that happened in the 90s and in the 80s in Chile and Colombia, well, have these equity problems. I agree.
Yeah. Absolutely, and probably he solved this change on the basis of efficiency gains, because it's easy to say that, look what's happening in the country. We have these hundreds of small insurance funds. They're not efficient. Let's use the private sector now to achieve better efficiency.
Yeah, on the other hand, I think that probably this will drive a consolidation of social health insurances, because 300 is absurd. It's absurd. The transactional costs, the administrative costs are absurd.
Yeah, absolutely. But as I said, it will be a consolidation of the bad risks and the bringing.
Oh, sure. Yeah.
So
this will
it's not going to
probably
solve
happen.
the problem. Yeah. Now let's take a few questions from our participants. We have a question from Rob Yates, who is a visiting professor in our research center. And he's asking, in the US, the Democrats have chosen falling access to healthcare as their number one issue on taking on Donald Trump, even shutting down the government over this issue. Is the opposition in Argentina likely to employ similar tactics? And do you think this political strategy could defeat Milei in your next elections, making health the big opposition claim?
It's very difficult to say, because really, the problem in Argentina now is there is no opposition. It doesn't exist anymore. The Peronist opposition is totally dissolved. Or will be dissolved. And when I was Minister of Health, my party was a radical party, was a center to the left party, a social democrat. It's dissolved. So there's no opposition now. I don't know what will happen from now to 2027, the next presidential election, but since public health is not an issue in the governmental agenda or in the social agenda after COVID, I don't think that it will happen.
Okay, thank you. We have another lengthy question from Walter Colasante, and I'll try to summarize it. It's about access to new innovative medicines. Some of them are very expensive, and with all these changes and the two-speed insurance system, who is going to have access to innovative medicine? Is this going to be only for the rich population with private insurance?
Well, Argentina has a very large access to drugs, even innovative drugs, in all sectors. And the creation of a health technology assessment agency to guide coverage decisions would be an important step to regulate that. Because the problem with high innovative drugs is a global problem. But of course, in middle-income countries such as Argentinian countries or other countries in Latin America, is a worse problem. I would say that probably, for instance, the funds, the social security funds to cover high-cost, high-price drugs is almost exhausted now. So probably, if we don't do anything, and the current government is, regulation is an anathema for Milei, is an anathema. Anathema is okay, what I say? You understand, anathema. I would be very much concerned about access to high innovative drugs of poor people in the future. Now, they have access. They do have. In the future, I doubt it.
Thank you. We have a question from Bill Xiao, who modestly presents himself as a health economist at Harvard. He's probably the most famous health economist. And
I know him very well.
Thank you, Bill, for attending this session. And his question is often a nation reforms its health system because of inequity and inefficiency. Why Argentina did not consolidate your two major health financing programs and create a universal health insurance system before? Is there a serious inefficiency in Argentina health system that caused Milei to turn to the market forces? It's similar to the question I asked you before, in fact.
Well, I think that it's very unlikely that Argentina could have a national health insurance because of the history, the culture. You know, it's very difficult to translate from one country to another country. I wouldn't see that. I would be happy if we could build a system that integrate and articulate better. I mean, social security, the public sector and the private sector. I don't think it's likely to have just one national health system. Not now, at least.
Thank you. A question from Professor Joan Costafont from the LSE. Can regional states expand and fight back? Can the region join the World Health Organization irrespective of the federal government? There are two questions here.
I think I'm not understanding very well.
The first question is about the regions, whether they can expand and fight back.
Which regions? I mean,
your federal states. Your federal states.
Yeah, of course. I mean, I'm not sure whether it will really take place, this withdrawal from the WHO. I mean, at least it was said at the beginning of the year, and then nobody talked about that anymore. So I'm not sure. I'm not sure. Of course, if Trump finally decides to withdraw from WHO, probably Argentina will follow. But I'm not sure, because they said, okay, we are not. I mean, we're gonna exit from WHO, but not from PAHO, and I don't understand very well this.
Yeah.
How can you stay in PAHO and not in the WHO? Although there are different organizations, because I don't know if you know that PAHO was established before the WHO. Because and there are two different organizations, but PAHO represents the WHO in the region of the Americas. So it's not, and 40% of the, or at least 40% of the PAHO's budget comes from WHO. So I don't think that you can say, I mean, okay, we are withdrawing. I mean, we are getting out from WHO, but not from PAHO. Mm-hmm. So let's wait what will happen.
Let me see. Many questions. A question from one of our students, Ariana Garcia Modufar. She's from Lima in Peru. The question is there already a visible difference in healthcare quality now that regional governments have had more health responsibilities translated to them?
When you say regional, it's provinces. You're talking about provinces.
About
okay,
provinces,
okay.
Yeah.
Well, yeah, there are a lot of tensions. A lot of tensions right now. For instance, I don't know if whether it will happen, but one of the largest programs of ambulatory medicines, to delivery of ambulatory medicines to vulnerable populations for the public sector in the provinces is going to be dismantled, or is said that could be dismantled. And so the provinces should the medicines without an allocated budget. So there are going to be a lot of tensions, and this is just one example.
Excellent. We have another question from Vishal Kleptpal. Sorry for mispronouncing your name, Vishal. He's a former student and he's currently fellow in cardiovascular disease at Brown University. He's curious what has been the public response, if any, to these changes to the health system. Obviously, they voted again for Milei, but are there any other reactions?
Well, there was I show you in a slide, the policy resilience. I mean, the Congress, for instance, impeded, some of the measures of Milei, for instance, to decrease the budgets of some national hospitals or the Agency for Disabled Persons, so there are some policy resilience that are taking place. Now, after this midterm election, the government has been empowered a lot. But again, what will happen in the next, 2 years in Argentina, from now to the next presidential election is like centuries in some other countries, and I mean it. So for instance, I was Minister of Health of a government, a coalition government, when the President Macri, in 2017, just a few months after my taking office, the government won the election. With the same numbers, the same figures that Milei's. And 2 or 3 months later, it was a mess. So nothing is granted. I don't know, but yeah, and there are a lot of policy resilience. Also, healthcare is not, I would say, it's not very, very high in the public agenda, in the social agenda. But when there are problems, when people, feel that really health can be compromised, that's another thing. And it's happening.
Yeah, absolutely. Thank you for pointing out that 2 years in Argentina are like centuries elsewhere. When I was a minister in my country of origin during the financial crisis, we used to say a day is like 100 years elsewhere.
Well, Greece and Argentina share a lot of things.
Yeah, absolutely. Another question from Hans Gevers, who is from Belgium and a PhD student at the Estonian Business School. The question is, given Milei highly values US expertise, do you expect that Milei can further privatize the healthcare system under US influence, or he will stop to the privatization?
No, I don't think so. Again, I think it's the political economy of that wouldn't allow him to do that. No, I don't think so.
Okay, we have another question from another former student, Jorge Garcia, who is from Colombia, and he's currently working for the WHO Barcelona office for health system financing. The question is as follows: I guess people in Argentina cannot counteract Milei's populist discourse merely by showing more science-backed evidence. The government seems not to be interested in evidence-based solutions.
Not at all.
Yeah. What has been the response from academics or the civil society to counteract the policies introduced by Milei?
Well, it depends. I wouldn't say that. I wouldn't say that the academia is mobilizing a lot. I wouldn't say so far. But I agree that evidence-based policy is not something that is the Milei caring about.
Great. We have another question from a student at the LSE, Tobias Bianche, and he's asking us to whether there is any scientific evidence of the effects of Milei's defunding and privatizing of the healthcare system, for example, on out-of-pocket spending, access to healthcare. And you also said that the population of Argentina still supports Milei. Do they already notice changes in healthcare coverage? And do you think that a worsening of coverage will significantly influence their support for Milei?
Well, maybe. This is something that we have to, we have to examine, not now, but probably in 1 or 2 years, and maybe with you, Elias, we can monitor what will happen.
Yeah, absolutely.
But I think there are gonna be some reactions, some pullback, probably.
Yeah, those of you who are attending this session, we have with us Ana Riviere-Sinamont, another former student who is the PAHO WHO representative to Panama, and she has provided a response about PAHO and what happens with PAHO and WHO relations.
What does she say?
It's a very lengthy response, and we don't have much time, but
I'm interested in
and we can disseminate it to the participants. Then we have another Colombian here, Lina Esteban, who is a general practitioner from Colombia and an MSc student. In this context of moral austerity, and now that Argentina is stepping away from WHO, how can countries like ours, already facing weak immunization, lack of basic medicines, and cuts to programs like the USAID programs cuts, be prepared for another outbreak or pandemic?
Well, that's a challenge. That's a challenge, and what is happening. This is what I tried to say when I was when I mentioned that we should reimagine the global health architecture after the withdrawal of the dissolution of the USAID agency and some other agency, because there is a retreat even in Europe to fund the global health, and in my region in Latin America, we are in a big problem because we are not that poor as to receive a decreasing global health funds.
Yeah.
Because the global health funds are now directed to Africa or maybe Central Asia or South Asia. But we are not, we are either not so rich to go, to go independently. So we really are in the middle and with a lot of problems. I don't know what will happen. I would say that, for instance, this withdrawal from WHO, if it happens, will put us out of the global health conversation, but not only the global health conversation, but also, all the global movement of preparedness and response to a pandemic. And again, I don't know what the representative of PAHO said. I will read it, but I don't know what happened with PAHO. Because PAHO has, for instance, the revolving fund, and revolving fund is very important to get vaccines, for instance, for all the Latin American countries at a very low price. And what will happen if we exit WHO? Can we stay in the PAHO? Well, that's not very clear right now, in my opinion.
Thank you, Adolfo. I'll only take another question only because we are time limited. It's from Julia Garcia Luscaren. She's a New York University student studying public health and neuroscience from Mexico and Uruguay. How would you propose using additional funding to aid public health access? In countries that have increased funding for public health, does this funding necessarily correlate with better outcomes? And what are other alternatives?
Well, it's difficult to answer that question. So I really don't know. It's not just a question of funds. It's not just a question to put more money. It's more complex. It's more complex. I don't know.
Thank you, Adolfo, again for giving this excellent lecture, and thank you for the interaction with our participants and our students, and thank you all for joining us today. Thank you very much.
Thank you, Elias, and thank you all.